Hello, folks. We are going to have a brief discussion today on clinical supervision. This is part one, the basic training. My name is Nick Crapser. We are going to go through this presentation a little faster than intended due to the fact that we don't have audience participation for this presentation. What I would encourage you to do is take some notes, jot some things down, talk to your supervisor if you have questions. And as I said, the audience participation piece that we're lacking in this recorded presentation is going to get us through this presentation much faster than normal. So today's presentation overview, we're going to talk a little bit about what a clinical supervision self-assessment looks like. We're going to grade ourselves silently on the clinical supervision self-assessment. Then we're going to talk briefly about what clinical supervision is and what clinical supervision is not. We're going to have an overview of ethical codes and supervision questionnaires. We're going to do a brief overview of clinical supervision models. And lastly, we're going to do an overview of future clinical supervision trainings. So there are 3 clinical supervision trainings in this series. The first one is basic. The second one is intermediate, and the third one is advanced. So the objectives for the clinical supervision trainings in their entirety is to remember the basics of why we are called to supervise, develop a deeper understanding of the purpose behind clinical supervision, learn how to apply ethical codes to our clinical supervision practice. We're going to critically analyze some literature on clinical supervision models. We're going to evaluate which clinical supervision models would most benefit our counseling staff, in turn, most benefiting our patient care. And lastly, we're going to create cohesion amongst clinical supervisors and the supervision being provided to clinicians throughout our organization. So this is the clinical supervision self-assessment. Please give yourself 1 point for yes, 0 points for no. If you are doing this as a continuing education, you're already an employee of Serenity Lane, just go ahead and think about the last time that you supervised people. If you're a new employee and you're doing this through Elias, think about your last supervision job that you supervised people. And if you are a new supervisor, just bear with us as we get through this self-assessment. Those that I supervise have a thorough understanding of their goals and can easily recall their goals for clinical supervision. Once again, give yourself 1 point for yes or 0 points for no. Number 2, those that I supervise know which goals are proximal goals and which are distal goals and why each are important to this process. Number 3, those that I supervise understand that we will check in during supervision on both proximal and distal goals. Number 4, those that I supervise understand the true purpose of clinical supervision. Number 5, those that I supervise understand my personal counseling orientation and my supervision orientation. Number 6, those that I supervise can send agenda items ahead of our weekly designated supervision time. Number 7, those that I supervise understand that there is seldom an unchanging structure to our supervision time. Number 8, those that I supervise can count on consistent recurring supervision, a consistent recurring supervision time weekly or twice monthly. Number 9, those that I supervise understand the difference between a counselor and a clinical supervisor and do not treat our time together as a counseling session. And finally, number 10, those that I supervise have signed a supervision contract agreement with me as their supervisor. So once again, give yourself 1 point for yes and 0 points for no. Now, the idea behind this is that it's not a pass-fail, but the idea behind this self-assessment is that we can critically look at ourselves and the supervision that we've provided people in the past or that we're currently providing people. And with that information, armed with that information, we will be able to make some changes. And hopefully by the end of this series of trainings, you will be able to see how you can start implementing those changes more or better in your clinical supervision practice. So what clinical supervision is? This is from Bernard and Goodyear, 2014. Supervision is an intervention provided by a senior member of a profession to a more junior colleague. This relationship is evaluative and hierarchical, extends over time, and has simultaneous purposes of enhancing the professional functioning of the junior person, monitoring the quality of the professional services offered to clients, and serving as a gatekeeper to the profession. So there's some really important key words here that I would like for folks watching this to keep in mind. Evaluative, hierarchical, extends over time, simultaneous purposes, quality of professional services, and probably the most important, a gatekeeper to the profession. So we will address a lot of these as we go, but try to keep those in mind as we are moving through the slides. What clinical supervision is? Clinical supervision is the place for the supervisor to work with the counselor to create proximal or short-term and distal longer-term goals and check in with the counselor about achieving these goals during supervision sessions. Clinical supervision is the place to discuss patients that are not easily conceptualized or understood by the counselor, or patients that, for one reason or another, are causing the counselor pause. Now, I use the word pause in this slide on purpose because I'm trying to say that the person that you're supervising is not at a loss, or it's not that they don't know what to do, but it's causing them pause. So it's causing them to slow down and to think about the conceptualization of the case, or how easily they understand what's happening with the case, which is another one of the values of supervision, to discuss these cases with their supervisor, who not only provides a fresh voice for the counselor, but hopefully has more experience in the field and can offer some suggestions that are helpful, or maybe some insight for the counselor to see how they can better serve their patient. Clinical supervision is the place for ethical discussions to take place and for the counselor to gain a better understanding of ethics as they apply to their individual practice. Clinical supervision is the time for counselors to discuss multicultural considerations with their supervisor and explore their own potential blind spots. This is another one I was very intentional about using the word blind spot. Most of the time, when we think of a blind spot, it's something that is blind to the driver or is blind to the person that's actually doing the job. We like to use the term blind spot because these are normally something that's not something that's intentional, and therefore it is something that is unbeknownst to the counselor. So during supervision, this might be a good opportunity to talk about some of those potential blind spots. And the last bullet on the page, clinical supervision is about counselor training, growth, and gatekeeping for the profession. We think of gatekeeping as the person standing at the gate who allows folks to come into the gate or does not allow them to come into the gate. And we have a great responsibility as counselors that are providing gatekeeping, in the sense that we are responsible for those who enter the field. So the licensing boards that certify counselors are responsible for giving the exams and making sure that all of the boxes are checked, but they've not had a chance to see the counselor in motion. They've not had a chance to observe the counselor with their patients, and it's very difficult for them to give formative feedback or evaluative feedback because there are so many people that are requesting licensure. So they are leaving that into the hands of the supervisors, the counselor supervisors, and the educational programs to become or to be the gatekeepers of the profession. What clinical supervision is not. Clinical supervision is not human resources. At Serenity Lane, we have an incredible group of human resource professionals that can assist with HR needs. Clinical supervision is not the same as administrative supervision, although in some agencies, some duties may overlap. And that comes directly from the Tip 52, which we will talk about soon. Clinical supervision is not conflict resolution between counselors, although with this bullet point too, there may be some overlap. Also remember our great team of professionals in HR for this as well. Clinical supervision is not your supervisee's professional counseling session. This distinction must be drawn early in supervision. Now, what I'd like you to think about, this was a really good discussion point for when we were doing this training live. What I'd like for you to think about is the problems that could arise if you allow the counselor to come in and treat this supervision time as their own personal counseling session. It's one of the dangers that supervisors run into, and they sort of allow it to happen at times. And then there are issues or problems that evolve because of that. The next bullet point, clinical supervision is not time for you and your supervisee to become friends. Will friendships happen over the course of working together? Well, naturally, yes, they might. But there's some pretty clear distinctions that the ACA and the NADAC and the APA Code of Ethics talk about when supervising friends. And the ethical code is that we do not supervise friends. Can you think of anything else that clinical supervision is not? We're going to go into a couple of the ethical codes regarding clinical supervision. Here's the NADAC Code of Ethics. Section 7-2 talks about training. Addiction professionals shall complete clinical supervision training prior to providing clinical supervision to students or other professionals. So once again, this is not to get anybody or to make anybody feel like they were not trained well, but the reality is that many times in agencies, we push folks that were good counselors into becoming supervisors, and we don't give them the professional training that they need or make sure that they are signed up for it. Therefore, we're definitely not providing them with what they need to do the job correctly or up to par with the ethical code. Section 7-5, informed consent. Supervisees shall provide the client with a written professional disclosure statement. What the rest of this one talks about is how a supervisee or a person that is not licensed or a student will be consulting with people that are managers or other people in the organization, and the folks that they are counseling should know that. Section 7-16, clients. Supervisees shall disclose to clients their status as students and supervisees and shall provide an explanation as to how that affects the limits of confidentiality. So in that one, we're discussing the fact that that it's absolutely important for counselors that are supervisees or that are students to let folks know that they're counseling what their licensure actually is, or that they do not have a license, or that they're interns. A lot of times what happens as patients that come into a treatment center, they hear counselor and they think, oh, that person could be a prescriber, a psychiatrist, a psychologist, a mental health counselor. The average consumer does not have any idea what the acronyms or the abbreviations are after somebody's name. So it's very helpful. It's very ethical to share that with patients. Section 7-18, observations. Clinical supervisors shall provide and document regular supervision sessions with the supervisee. This needs to be done in the form of record keeping. Also, it provides proof that that took place for licensure for the person. And also, we're told that we should be providing ongoing feedback regarding the supervisee's performance. And 7-19, clinical supervisors shall be aware of their responsibilities as the addiction professionals the addiction profession's gatekeepers. So we talked about this a little bit, how important it is that our job is to be the gatekeeper of the profession, regardless of what kind of a counselor, whether you're a substance use disorder counselor or a mental health counselor. Section 7-25 talks about dual relationships. Clinical supervisors shall not supervise relatives, romantic or sexual partners, personal friends, and it goes on with more of a list. Section 7-30, counseling. Clinical supervisors shall not provide counseling services to the supervisee. Supervisor shall assist the supervisee by providing referrals to appropriate services upon request. This is from the American Counseling Association, the ACA Code of Ethics. When I was going through the ACA Code of Ethics, I tried to find ones that were not, that were a little bit different from the NADAC Code of Ethics or that focused on something different. Section F2A, supervisor preparation. This is absolutely talking about being well prepared to become supervisors. This includes counselors who offer supervision services regularly, pursuing continuing education activities, and getting that formalized education. A lot of programs that are, designed to get students get a master's degree and move on to licensure. This is Those programs have little to no focus on supervision, so it's incumbent upon the counselor to seek out that extra education. F3D talks about friends or family members that were prohibited from engaging in a supervisory relationship with them. F6A is about evaluation. Supervisors document and provide supervisees with ongoing feedback regarding that supervisory relationship. And then, of course, there is F6B on gatekeeping. Again, the focus on gatekeeping, how important our responsibility is. This is the APA Code of Ethics. Supervision is actually only mentioned 7 times in the APA Code of Ethics. And the reason for that is because in a psychologist educational program, there is a lot of focus on supervision. And so that's sort of part of the program, whereas with a master's degree in counseling, most master's programs have very little to no focus. In fact, using my own program, there was no focus on clinical supervision whatsoever. I had to get that education in my PhD program. So before we go into this slide, what I would like to do is take you to the internet and show you where we can get a couple of those Code of Ethics from. It's pretty easy to locate. Resources /ACA Code of Ethics. And the NADAC Code of Ethics is on their website. It breaks it all down here as principles. And then the American Psychological Association's Code of Ethics is on the web as well. For ease, what I have done is I put them into a shared folder on the Serenity Lane drive. It's located on the J drive under clinical outpatient, then outpatient branch supervision, and then the file is called the Clinical Supervision Toolbox. Now, what you're going to find on that toolbox are a variety of things, which include excuse me for just one second here, which includes Tip 52, which is a treatment improvement protocol, clinical supervision, and professional development of the substance abuse counselor. This is 21 pages long. The next one is something similar. Much larger book, but this has a review of some literature. This is also part of Tip 52. Then you're going to have a series of measurements and scales, which we're going to talk about here in just a minute. There's also some forms from the state. This is for the Oregon Board of Licensed Professional Counselors and Therapists, the OBLPCT. These are supervision forms. I would encourage you to go navigate around a little bit in there and take a look at that and see if there are things that you have questions on. The next few slides that we're going to talk about have to do with supervision scales or tests and measurements. So this first one is called the group supervision scale. One of the things that I've really enjoyed about providing supervision for people is the group supervision aspect. The group supervision aspect, this is a 16 question exam or test, a screening tool, if you will. Some of the questions on there focus on feedback. Some of the questions are helpful suggestions. Get familiar with this. At Serenity Lane, what we're going to do is come up with a combination of these so that we can provide to our staff so we can get feedback about the supervision that they're receiving. This one's called the Supervisee Needs Index. It's very similar to the last one, but this is focusing on specific individual supervision. Some of the things that were discussed during supervision, the safety of the individual during supervision, talked about roles a little bit, and some personal opinion parts on how the supervision went. This is the continued, this is a total of 48 with some scoring questions on it or some scoring procedures on it. This next one is a pretty simple, straightforward one. This is an 8-question supervisory satisfaction questionnaire. So what I'd like you to be thinking about while you're looking at this one is, what would your supervisees say about you if they were doing this? This next one is the longest one of all. This is called the Supervisory Relationship Questionnaire, the SRQ. It goes in sections, and I've broken down the sections. And at the top of this up here, where you'll see my cursor, I include this scale at the top of each one of these subsections, although that's not the way that it is in the form, just so that you can see how you'd be rated. So this section right here that we're looking at is on SAFE, the SAFE-based subscale. The next one is on the structure subscale, so how those supervision sections are structured. Commitment subscale, reflective education subscale, role model subscale, formative feedback subscale, and then there's the scoring key for it. So we're going to get into models of clinical supervision a little bit. There's three primary models of clinical supervision, and within them there are sublevels as well. So models of supervision grounded in psychotherapy models. So we have a list of psychodynamic, humanistic, cognitive behavioral, systemic, constructivist, narrative, and solution focused. As the name implies, these models are grounded in psychotherapy models that are already familiar to counselors and supervisees. These models of supervision are the second most popular models amongst counselors, counselor educators, and licensed counselor supervisors. That sounds great that they're the second most popular, but there's really only three, so it's not as awesome as it sounds. There's pros and cons to each of these. One of the notable cons of this one that should be talked about for a little bit is what many of you are probably already thinking already, which is if you're used to using these in a counseling relationship, then it may be difficult to shift out of a counseling relationship for these and into a supervisee relationship. We talked about the importance of not providing counseling for a supervisee. So what if you were using these, would it look like you were providing counseling, or how could you make that shift in that delineation there to let the individual that you're supervising know that you are not providing counseling for them, but indeed providing supervision? The next one is developmental models. These are the least popular. These are the least popular clinical supervision models. Some of the developmental models are the Logan, Bill, Hardy, and Delworth, the IDM, the systemic cognitive developmental supervision model, the reflective developmental models, or the lifespan models. As the name implies, these models are developmental and rely on stages and identification on the part of the supervisor, which stage of development the supervisee is or supervisee is in. And like I said, the developmental models of supervision are likely the least popular amongst counselors, psychologists, counselor educators, and licensed supervisors. The last model of supervision that we're going to talk about is process models. This includes the discrimination model, events-based model, Hawkins and Shohet model, and the systems approach to supervision, or the SAS Holloway model. Process models of supervision attempt to explain the activity of supervision from a variety of vantage points. Process models of supervision are the most popular amongst counselors, counselor educators, and licensed supervisors. So these process models allow flow to happen in the session, whereas the previous slide, what we talked about, is a stage. In the process model, a person could come into supervision today in one particular stage, and the next time they come into supervision be in a completely different stage. It's less linear and more process focused. So the next clinical supervision training that you will see on your Relias is going to be a discussion, is the intermediate training, and it'll be a discussion of psychotherapy models of supervision in detail, developmental models of supervision in detail, process models of supervision in detail. And those would be these three last slides that we talked about, these models of supervision. So I know we just blew through those really quickly, but in the next clinical supervision training, we are going to go into those much more in detail. And then the final clinical supervision training that you will find in Relias, we'll be putting it all together. We will have a great discussion about operationalizing or manualizing clinical supervision. Rich discussion about documentation, ORS, CARF, etc., supervision evaluation, And we'll talk about how we can improve processes at Serenity Lane with perhaps some fidelity reviews, audio or video supervision and sit-ins. So as mentioned a couple times earlier, this is a much shorter presentation than what it would be if we had a live discussion, because this last slide got a lot of really good comments and further discussion from the people who were participants. Some of the questions and discussion that I'd like for you to be thinking about as you're watching this: what areas did we discuss so far that are intriguing to you? Which are reviews for you? Which are areas that you would like some more education around? What areas do you have some fear around? What questions will you be looking for answers from moving forward? What are you ready to take from today and apply tomorrow? Are there areas of discussion that you'd like to know more about, or that you'd just like to talk about? And questions in general. So hopefully you find you found this discussion interesting. I encourage you from the beginning to take some notes and to write out some questions. If you do, please feel free to email me or your supervisor or somebody else that you might be able to get some good information from and have a further discussion about this. There will be much more information in future trainings, and hopefully you'll be able to catch a clinical supervision training live and enjoy the discussion that comes as a result of it. Thank you very much for paying attention, and have a wonderful afternoon.